Yeah, good evening. On the behalf of Sun Pharma, myself Neeraj Sharma, welcome to all the eminent doctors for today's webinar on interactive clinical case scenarios from renowned experts in the field of gastroenterology and hepatology. I welcome moderator Professor Philip Abraham, senior gastroenterologist, PD Hinduja Hospital, Mumbai, and moderator Dr. Anirudh Padke, senior gastroenterologist, Leelavati Hospital, Mumbai. Now, I request Professor Philip Abraham to introduce speaker Dr. Akash Shukla.
Good evening,
Sir.
friends. It's always a pleasure to introduce Akash because I'm a little lost because I didn't know where to start and where to end. Akash has been a very close and reliable friend all these years. As you know, he's the professor and head of the Department of Gastroenterology at the KEM Hospital. Before that, he was at the head of the department at Sion Hospital, both in Mumbai, and one of the bright stars on the horizon. Now he's moved away from the horizon into the limelight, and he's going to teach us a few things by using case studies as examples. My fellow moderator, Dr. Anirudh Fadke, also has been a colleague of mine, excellent clinician, no doubt. And I wouldn't think twice if a patient has been seen by Anirudh, because then you know he's got the final word in the field. So it's a privilege for me. I'm really privileged to be in the company of these two stalwarts of gastroenterology and hepatology. And I'm sure that you'll enjoy the next hour and a half while they discuss cases. I was reminding Akash earlier this evening that the moderator's job is only to moderate if there's a dispute. Otherwise, the wisdom comes from one moderator, Dr. Fadke, and from Professor Shukla. So we won't take your time now. I'll request Professor Shukla to go ahead with the case presentation.
Thank you, sir. Good evening, everybody. Thank you, sir, for giving me those kind words of introduction. It's always an honor to share the screen space with you and share my thoughts on these common case scenarios that we are having. Uh, and Thank you, Professor Fadke and Professor Abraham for moderating this session. Without much ado, I'll start. At the onset, I would like to request we will be keeping this as interactive as possible. So I would request the audience to keep on typing their questions in the Q&A, and we will be taking up cases even in the middle of the session, not at the end. So as the case ends, we will discuss the case. And unlike what Professor Abraham has requested, we would pick his brains and get pearls of wisdom from his practice, as well as from Anirudh Fadke sir at different levels of the case. So starting with the first case, here is a 40-year-old gentleman. He has a BMI of 41, recently detected to have hypertension. He doesn't have any addictions, no history of alcohol consumption. He undergoes a routine health checkup, executive health checkup, and found to have grade 3 fatty liver on ultrasound. His SGOT, SGPT is 80 and 144. Rest of the LFT is normal. His lipid profile shows a cholesterol of 356, LDL of 186, triglycerides are 288. HbA1c is on the higher side, 6.6, but nothing alarming. His WBC count is 7,800, hemoglobin is 13.2, platelets are 2 lakhs. So in this patient, how do you really see whether this liver problem, this fatty liver, is sinister or it is not? That means, is this patient likely to have fibrosis of the liver, cirrhosis of the liver, or not? The ultrasound has just shown grade 3 fatty liver. Now, usually when you see a fatty liver, what are the things that you look for? The first thing that you look for is the platelet count. If the platelet count is below 2 lakhs, you should immediately start suspecting that the patient may be having some sort of fibrosis in the liver. If you find that the liver is surface of the liver is irregular or nodular, then that should immediately raise suspicion of cirrhosis. If you find splenomegaly on ultrasound, then you should immediately think whether you're dealing with cirrhosis or not. So these are some of the pointers. Other pointer is a low albumin level. So if you have a patient with grade 3 fatty liver, the albumin is 3.2, you should suspect cirrhosis. So these are some of the things which you should keep in mind. For more subtle things, you look at something called as APRI. Now, what is this APRI? It is a very, very simple calculation. All you need is SGOT levels and the platelet count. So you look at the patient's SGOT, you divide this by the upper limit of normal of the lab of SGOT and divide the whole thing by the platelet count in thousands. So if the patient has a platelet count of, let's say, 1,65,000, then you write 165. So in our case, the patient's SGOT was 80, upper limit of normal is 40. Divide the whole thing by 2 lakhs, so that is 200,000, so 200 multiplied by 100, which makes it 1. So what does this 1 mean? Anybody who has an APRI of less than 0.5 does not have fibrosis. Anybody who has an APRI of more than 1.5, in all probability, has cirrhosis. In somebody who has a value between 0.5 to 1.5, there is a likelihood that he may have liver fibrosis and you need to investigate further. A somewhat more complicated, but probably slightly more reliable formula is a FIB4, which is age in years multiplied by AST levels, whole thing divided by platelet count in, again, thousands multiplied by square root of ALT. So in this patient, FIB4 is calculated to be 1.33. Same question, how do you interpret? A value of less than 1.45 rules out advanced fibrosis, and a value of more than 3.25 suggests advanced fibrosis. So here in our patient, it was around the lower limit of normal. So we went ahead and did a fibroscan, which was found to be 9.5. Now, fibroscan itself may be slightly unreliable in people who are obese. Our patient is having a BMI of 41. And therefore, the fibroscan, even with the Excel probe, is actually not very reliable. It can overestimate the liver stiffness. Now, the next question comes, how do you investigate whether these high enzymes are only because of fatty liver or because of something else? So we do hepatitis B and C tests in almost everybody with any liver function abnormality. So they came back negative. So the next question is, do you really investigate further? At this stage, I would like to ask Professor Abraham, when he sees patients who have a risk factor for fatty liver disease and hepatitis B and C are negative, does he always rule out other etiologies like autoimmune Wilson's or not?
All right. Before I get to the answer of that, one of the points that I would like to mention here is the importance of GGT. In a patient with elevated GGT, of course, you would always suspect that this patient has some element of fibrosis. I mentioned that only because that's generally an ignored parameter in the liver function test. All of us look at all the rest and think of GGT as just a bystander, but that's an important parameter for recognizing fibrosis. If it's high, you know that there is something more than just inflammation, although there's no linear correlation. Coming back to the question that Professor Shukla asked, the decision to go further with investigation also depends on the clinical context. So if it's a young person, of course, you would not stop at Hep B and Hep C. You'd also want to evaluate for Wilson's disease, for example. We're just talking about who are the ones who are more prone to it. Wilson's disease in a young person, autoimmune hepatitis in a young or middle-aged individual, particularly among women. So the decision to do further tests will depend on, like I said, the age and gender of the individual. If I find fatty liver in someone who's 65 or 70 and has diabetes and has the metabolic syndrome and no other evidence of any disease prior to this, I probably would not go beyond Hep B and Hep C. So it depends on the age, the gender, and the future of the individual. What are we likely to achieve by investigating more?
Thank you, sir. I completely agree with you, especially on the GGT point. So GGT is a very important marker of liver fibrosis in the absence of alcohol consumption. So in the presence of alcohol consumption, it becomes a marker of recent alcohol intake. In the absence of alcohol consumption, it's a very, very important marker of liver fibrosis. So here in this patient, because we were finding the biopsy, we were finding the FibroScan unreliable, and the family wanted to really know whether he really has NASH or not. All of the markers were negative. So we went ahead with a liver biopsy. Usually we would not do liver biopsy for most patients if the diagnosis is clear cut. But here it was done because the patient was insistent. And what we see on liver biopsy is a lot of macrosteatosis, almost to the tune of 70%. And there is inflammation in the portal tract, some inflammation in the liver parenchyma. And if you can see carefully, there is beautiful chicken wire fibrosis around the hepatocytes, which you can see as the dark pink material. So this patient was recently diagnosed to have hypertension, had mildly elevated HbA1c, had dyslipidemia with high LDL levels. So he was started on vitamin E, telmisartan, metformin, and atorvastatin 10 milligrams, along with the lifestyle modification, which is the single most important intervention in patients with non-alcoholic fatty liver disease or metabolic fatty liver disease. After 3 months, this patient's BMI reduced from 41 to 38. His BP was well controlled. HbA1c had come down to 5.7. The insulin resistance had improved. The HOMA-IR from above 3 had come down to 2.4. The SGOT, SGPT levels remained the same. The lipid profile had improved. The LDL from 186 had come down to 126. Now, this is slightly unusual because if you lose around 7% of the body weight, you expect a significant improvement in the liver histology as well as improvement in the transaminases. So here the patient's BMI had come down from 41 to 38, but the SGOT, SGP did not improve, although everything else had improved. So this can happen in around 30% of the patients. So we decided to continue with the same treatment because he was losing weight. We thought that we should wait for 3 more months and observe. So now after 6 months, that is 6 months from the intervention, 3 months from the last follow-up, his BMI had come down to 35.2. Blood pressure was very well controlled. HbA1c was 5.6. The insulin resistance was well under control. The SGOT-PT was still high, 68 and 155. Lipids had improved further. The LDL was 116, although the triglycerides were still on the higher side, 248. So at this stage, what would you do next? We had the following options at this stage. 1, offer bariatric surgery. The problem is this person is anyways losing weight. From 41 BMI in 6 months, he has come to 35. So in real sense, he does not require a bariatric surgery for the treatment of his NASH. Same logic for the endoscopic bariatric procedure. So yes, we have the option, but I don't think this patient is going to benefit by that. Do we need to add saroglitazar, which will lower the triglycerides? It can normalize the enzymes. It can get rid of the extra fat of the liver. So that would be another option. Or do we add obeticholic acid, which is a new drug which has become available with us, which works more on fibrosis? I'll talk about it. Or should we just continue the lifestyle modifications and continue the same treatment? Or do something else, look for another reason why the enzymes are not improving. So I would like to ask Dr. Phadke, if you face such a situation, what is it that you would tend to do? Of course, there are no right or wrong answers here. It is a question of what would be your choice.
Yeah, so I am assuming that we have ruled out Wilson because he's 40 years, and we have ruled out other reasons like autoimmune and even celiac disease, although celiac rarely comes with very high enzymes. So adding saroglitazar seems a reasonable option here. Obeticholic acid, we still do not have enough long-term data or whether it changes long-term history of NASH. But in any case, atorvastatin does not reduce the triglycerides, and his triglycerides on 3 occasions have been more than 230 or so. So adding saroglitazar right now seems a better option. Other consideration here is whether to repeat a fibroscan since 6 months are over, to see whether there is worsening or there is improvement. Now, if fibroscan shows improvement, then just adding saroglitazar and continuing the weight loss program is a reasonable option.
Yeah, I would agree completely. So it was considered, but like I said, this patient really wanted a confirmed diagnosis. So we decided to repeat a liver biopsy for this patient. And the repeat biopsy showed almost complete disappearance of the fat. But surprisingly, the inflammation had actually increased. And what we found was that there were a lot of lymphocytes, but a lot of eosinophils as well, with hardly any cholestasis, no intrahepatic cholestasis. There was still F1 fibrosis, although the thickness of those of the bands, I don't know if you can appreciate on this, but the thickness of those chicken wire fibrosis were actually lesser. So what we know for sure is that the steatosis has improved in this patient with a BMI reduction of 6. The fibrosis appears to be improving, which is again well documented in people who lose significant amount of weight. But the inflammation has increased and there is now eosinophils. So whenever you get eosinophils in liver biopsy like this with increase in lymphocytes, we must always think of drug-induced liver injury. So here, telmisartan was stopped. So immediately the question comes, why did we stop telmisartan and not the statins? Because we all would almost always get tempted to think that statins are responsible for hepatotoxicity more than telmisartan. So this patient, LFT was normalized in 4 weeks after starting ramipril. The reason of stopping telmisartan was the absence of cholestasis on liver biopsy. When you have statin-induced hepatic injury, almost always you will get intrahepatic cholestasis. So here we did not have any cholestasis. Therefore, the second likely drug was telmisartan. Now, telmisartan is actually a rare cause of drug-induced liver injury. It is not common. So in fact, the prevalence is around 1 in 10,000. The problem is because so many of the patients are on ARBs now, the denominator becomes very high. Therefore, once in a while, you'll get a patient with the telmisartan-induced liver injury. This doesn't mean that we should stop using telmisartan. It is the best drug for hypertension. It is the first-line drug. It's only when you have a person where you cannot explain elevated enzymes over a period of time, who is on ARB, you have ruled out all other causes. Please remember that telmisartan or other ARBs could be the cause. He has lost further weight now. His BMI is 33 and he is continued on the same medications. This brings us to a question, when do we give drugs which target the NASH in a patient with fatty liver disease? That means when do you want to give a drug for the liver issues in somebody who has got NASH metabolic syndrome? If the patient has come to you very early, when there is no inflammation, when there is only fat in the liver, this patient has a very low likelihood of having a progressive liver injury at that stage or dying because of liver disease. This patient has a higher chance of mortality because of coronary artery disease or a malignancy outside the liver. And these patients, therefore, should be followed up with physicians, and what we need is a general improvement in the metabolic parameters and management of metabolic syndrome with either lifestyle interventions, comorbidity treatment, or bariatric intervention, whatever is required according to the persons.
Akash, if I may ask a question in between here, sorry to interrupt. We talked about grading fibrosis, staging, and then, detecting and then grading fibrosis or staging fibrosis. How is anybody to know that the person has gone from stage 0 to stage 1?
Yes,
we have NAFL, which is bland fatty liver, to steatohepatitis. And then we talked about fibrosis. How is a physician to know that they've gone from bland fatty liver to steatohepatitis before they can even go to a stage of fibrosis?
Yeah. So one of the ways to know that the patient has steatohepatitis is high SGOT-SGPT. Of course, you may have steatohepatitis with normal SGOT-PT. Liver biopsy is the only definitive means to prove that somebody has steatohepatitis. But in real life practice, the elevated transaminases are a good surrogate marker for elevated enzymes, for NASH. Now, the problem with is in diagnosing whether the patient has fibrosis or not. For that, I would suggest that in your routine practice, start looking at APRI. That is a very, very simple tool. You only need to look at the SGOT and the platelet count and incorporate it in your routine algorithm. If the APRI is abnormal, please think that this patient would have fibrosis and you already reached the stage 1 or 2. Of course, stage 3 and 4 is the stage of advanced fibrosis and cirrhosis, which will not be very difficult to pick up on radiology, low platelet count, or other parameters that we have already discussed. It is in stage 1 and 2, that is a fibrosis stage, where you would require other surrogate markers or non-invasive markers of liver fibrosis like FibroScan or MR elastography or RFE to make a diagnosis of significant fibrosis. So in a nutshell, normal enzymes, normal APRI, all other parameters normal except for fat in the liver is NAFL. Fat plus high enzymes, you can consider NASH. Once fibrosis sets in, your APRI will become abnormal, FibroScan will become abnormal, or MR elastography or RFE will become abnormal. The enzymes may actually normalize at this stage. So do not get misled by normal enzymes. Of course, in fibrosis, you'll have abnormalities of multiple parameters, especially you'll get slightly lower platelet counts like 1,70,000, 1,80,000, 1,60,000. They may not be 1 lakh or 90,000. Don't wait for that platelet count. And you would have, in the absence of alcohol, an elevated GGT, mild splenic enlargement, surface nodularity of the liver, slight irregularity, coarse ecodexture. These are all the hints that will tell you that the patient is having advanced fibrosis or cirrhosis. So it is in patients who have stage 1 or 2 NASH, that is when fibrosis has set in, that is when the pharmacotherapy will actually make a difference. Once patient has become cirrhotic, then it is unlikely to benefit the patient. So too early in the disease, liver-directed therapy is not needed. Too late in the disease, once cirrhosis is already set in, the drugs may not be useful. So it is for that intermediate group of patients who have some fibrosis in the liver, that is when the drugs are actually required and also beneficial. So which are the conventional drugs that we have with us? So vitamin E across all the guidelines has been recommended. The advantage is it is effective at all the stages of NASH. The disadvantage is you cannot give it beyond 2 years because of the risk of hemorrhagic stroke, as well as the risk of increased bladder cancer with prolonged use. And unfortunately, it does not improve the underlying metabolic syndrome. The second drug which has been found useful in patients with NASH is pioglitazone. It improves the liver histology, and of course, it does control the sugar and metabolic syndrome. But the disadvantage is it causes weight gain and fluid retention. Metformin does not have an improvement in the, it does not cause any improvement in the NASH. This has been proven in meta-analysis. The advantage with metformin is it does produce modest weight loss and improves insulin sensitivity. So when you're treating somebody for NASH, it is a very useful drug to treat the metabolic syndrome. The newer drugs like semaglutide and empagliflozin, the GLP-1 RAs, and the SGLT2 inhibitors do improve the NASH, but themselves, they have side effects and they come at a cost. So those are the things to be kept in mind. And of course, there is no long-term data available to show that they can actually reverse fibrosis. So the new drug which is available with us is PPAR alpha gamma agonist, saroglitazar. PPAR alpha increases the fatty acid oxidation, improves the fatty acid uptake, and increases ApoA1 and HDL levels, and therefore reduces the inflammation and reduces triglycerides. The PPAR gamma activates the genes involved in glucose metabolism, thereby improving insulin sensitivity and increasing glucose uptake. And that is why this has got approved for non-cirrhotic NASH. The other drug which has been of some use is obeticholic acid, which is a FXR agonist. Now, theoretically, it targets multiple steps. Because it reduces free fatty acid synthesis and reduces de novo lipogenesis and gluconeogenesis, it can reduce the intrahepatic fat accumulation. Because it inhibits NF-kappa B and thereby suppresses inflammation, therefore it can potentially resolve the NASH. And because it inhibits stimulation of the hepatic stellate cells and inhibits TGF-beta-1, therefore theoretically it can inhibit and reverse fibrosis as well as prevent progression of fibrosis. But let us see, does it really translate into similar clinical benefits? So this was the REGENERATE study, which showed that almost 23% of patients treated with 25 mg of obeticholic acid had an improvement of at least one stage of liver fibrosis. With 10 mg, this came down to 17.6%. What is important here is almost 12% of patients in the placebo arm also had an improvement of liver fibrosis, which was probably because of the lifestyle modification, which goes on to reiterate how important is the lifestyle modification in not only resolution of NASH, but also improvement of fibrosis. So it can potentially reverse liver fibrosis as well. One stage improvement in fibrosis can be purely by chance, sampling error, or multiple reasons. What is more important is if there is a improvement in fibrosis by at least 2 stages. And in the arm with 25 mg of obeticholic acid was given, 13.3%, that is almost every 8th patient, had a significant improvement of fibrosis by at least 2 stages. This benefit was not there when treated with 10 mg of obeticholic acid. Surprisingly, there was no NASH resolution. So this does not reverse the steatosis. It does not prevent the inflammation, although theoretically we expected it to work at all the 3 levels. But it did improve liver fibrosis to some extent. But it was associated with significant adverse events. The 2 important adverse events were pruritus and increased LDL. So almost half of the patients who received the adequate therapeutic dose of 25 mg developed significant pruritus, and almost 17% of the patients developed higher LDL levels. And therefore, you have to understand that there are risks associated with this drug, and therefore it should be offered only to those patients who are likely to benefit and not to everybody with a fatty liver. So the learning points from this case: all fatty livers are not benign, but majority do not need gastroenterologist because most patients would be in F0 or the NAFL stage. Start using EPRI or FIB4 routinely to stratify your patients. Do not use them as diagnostic tools, but use them to just stratify your patients to identify those patients who are in stage 0. For those who have abnormal EPRI or FIB4, please evaluate them in more details whether they have liver fibrosis or not. So FibroScan or MR elastography or RFE would be done in some of these patients who have abnormal EPRI levels. Diagnosis of NASH is ideally histological, but is rarely done in clinical practice, and very often you would just rely on elevated transaminases to make a provisional diagnosis. Several drugs are now available for NASH therapy, but do not expect any magic results. Lifestyle modification remains the most important intervention for NASH. Finally, last but not the least, DILI may mimic NASH. Sir, would you want to add anything?
No, in fact, there are 2 questions here. One of them, of course, is there any method, this is Dr. Rajesh Upadhyay from Mumbai who has asked, is there any method for grading the disease?
So unfortunately for grading, that is the degree of inflammation, the only way is a liver biopsy, where you grade the inflammation in the portal area and in the lobule. So there is no other way to grade the disease.
We can keep going on and on discussing because this is such a hot topic, but there's two more questions that we have here. Dr. Shukla mentioned about the recent drugs, obeticholic acid and saroglitazar, but he didn't mention about the old drug. Vitamin E has been mentioned, but everybody's darling is UDCA. So would Dr. Phadke want to comment on his use of UDCA?
Yeah, so I'll tell you practically what happens. Over a period of last many years, UDCA became the thing in vogue. Then there were studies which were conflicting. Some said it benefits, some said it did not benefit. I think last AASLD guideline says don't use it. So I use it more as a, you can say, as a placebo. I don't know whether it works, but practically, if you have a 45-minute consultation with the patient on fatty liver, you tell him don't eat this, don't eat that, as such patient becomes depressed. And then at the end of it, you say you don't need any medication. Then he says, what the hell have I done for last 45 minutes? So because most of the patients inherently expect that they will get some prescription from you, rather than saying that run every day 50 minutes and don't eat sugary things, don't eat fried food. So those initial 2-3 months for their motivation, I think it is a safe option to give, because if at all it will benefit, I have not seen any data which says that it harms NASH patients. So it is more of because every few years new data comes and it says it is useful or it is not useful, but definitely no data which says that it positively harms the patient. So my feeling about NASH is that, and we have discussed this with Akash earlier, that nothing benefits as much as weight loss and lifestyle change. And everything else is, because all the trials are 12 months or maybe shorter duration than that, and this is a lifelong disease. So we are trying to extrapolate 12 months data with 25 years outcome, which is still not clear to me.
Your practice, but do you notice that, I don't know, it's totally anecdotal and non-controlled and whatever else, but does it help to normalize the transaminases? Is that why you continue to give it more than just as a placebo?
I don't know whether the weight loss helps or the change in because number of times when they change their diet and there is change in body composition, the weight may not change initially, but maybe once they do some resistance training and all, maybe their fat and muscle ratio may change and the weight may not drop by our target of 7%. So I have had some patients where they did not lose weight, but they just stopped sugar and they proved that their SGPT came to normal. Their weight did not change.
Mm-hmm.
So it's a very, very, tricky
Fluid,
thing.
yeah.
I don't know what is Akash's opinion on this.
So personally, I have not used ursodeoxycholic acid for NASH, I think in the last 5 years. So I have moved away from ursodeoxycholic acid, especially now with the drugs becoming available. So I think if it is a placebo, I think the way you talk to the patient is equally a placebo. Sometimes that will work. So
Anirudh, get that message. The way Dr. Shukla talks makes a difference.
Okay, now Akash, before we go to the next case, I have 2 questions.
Yeah, there are 2 questions.
The audience may also want to hear the answer. First is, you mentioned FibroScan in your patient was 9.5, but can you tell the audience what is the interpretation of that 9.5, what is normal and what is cirrhosis on FibroScan? That is first question. And second question is, you said for obeticholic acid that some patients will benefit. So can you elaborate on what is meant by some patients? How do you select patients for obeticholic?
Yes, sir. So FibroScan, the usual way to interpret is if the value is less than 8, it indicates absolutely normal liver. There is no stiffness. There is no fibrosis of the liver. any value above 13.5 should be considered as compatible with cirrhosis. Any value in between 8 and 13.5 is having some fibrosis. Now, when you interpret this, please understand that there is a huge inter-observer variability. It also depends on the way the probe is held, and it will change with even 1 degree change in the angle of the measurement. So this is something which is to be kept in mind when you look at FibroScan reports. So you don't need FibroScan in somebody who has obvious cirrhosis on ultrasound or CT scan. You do not require FibroScan for somebody whom you know is stage 0 NAFL. So it is required for those patients where APRI or FIB4 is abnormal, or there is some lab abnormality which has made you think whether this patient does have some liver fibrosis. Now, the second question, was about
which patients are best candidates
about obeticholic acid. Yeah. So the best group of patients who should be offered obeticholic acid in NASH is actually patients who have F2, F3 fibrosis, ideally biopsy proven. So if there is significant fibrosis in the liver, F2, F3 fibrosis, they have still not reached the stage of cirrhosis, then these are the patients where there may be some benefit. Even in them, only 1 out of 4 patients will actually have reversal of fibrosis, not everybody. So which is a small subgroup, but it is in this subgroup of patients where you would use this drug. Otherwise, the side effects cannot justify the use, despite whatever benefit there may be present with the use of this drug. And that's why the US FDA has not given approval for this particular indication.
So there are some more questions from the delegates. We probably will have time only for a yes/no kind of answer. Dr. Suprabhat, I think most of the questions are from Mumbai. Dr. Suprabhat has asked, can we use combination therapy in NASH? Yes or no? If so, vitamin E, UDCA, or obeticholic acid, saraglitazar. Forget about all the other metabolic syndrome medications. Do you use them in combination?
Yes. Even in the Regenerate trial, there was a combination of vitamin E and obeticholic acid. Even in the study of saroglitazar, vitamin E was permitted. So vitamin E with the newer agents, yes, not with ursodeoxycholic acid. I would again go and say not.
Yeah. Dr. Vidya Sindhu has asked, when do you suggest liver transplant? So my question is the indication for liver transplant different in NASH versus any other indication for liver transplant? And do you expect the changes to reverse after transplant in diabetics? The answer should be yes. But the first question, is it any different, the indication for transplant in NASH as compared to the others?
Yes. The threshold for transplant is lower for patients with NASH because they usually will not reverse. Most other etiologies, there is a component of reversibility. Even if they have decompensations like Hep B, Hep C, alcohol, there is some treatment which can theoretically at least stabilize or reverse. So, but in NASH, we know that once they decompensate, they deteriorate very rapidly. So I have a lower threshold for transplanting patients with NASH.
Okay. Again, a yes/no. Dr. Wag has asked, can you use FibroScan for judging transition from F0 to F1?
Yes, but not very reliable.
All right. Dr. Avar is the last question. She asks, what do you recommend for F2 and F3 fibrosis stage, that is? So effectively, it means you have an antifibrotic in addition to all the other drugs that you talked about.
Yes. So far, the only drug which has shown some benefit is obeticholic acid.
All right. So should we move to the next case then?
Yes, sir. So the second case is a 35-year-old gentleman. He has been consuming alcohol for last 10 years. He has jaundice for last 45 days, ascites since the last 10 days. Bilirubin is 26.4, SGOT is 123, ALT is 45, INR is 2.6. His CBC shows a hemoglobin of 10.9, WBC of 4,300, platelet of 78,000. Ultrasound shows cirrhosis, collaterals, ascites, splenomegaly. Patient has progressive jaundice. So at this stage, what is the provisional diagnosis? I think we would all be tempted and very easy to say that this is we are dealing with alcoholic hepatitis with alcoholic cirrhosis. So would you agree with me at this stage?
Yeah.
I'll just...
You want to go back? Yes.
Yeah.
Yeah. So it's very clear from you said from the previous case where we have a platelet count of 78,000 and an AST of 3 times upper limit of normal. And of course, the INR of 2.6 with the sonography showing cirrhosis. There's no going back on that at all. The diagnosis is clear. And OT more than PT in this case points towards, of course, this is a cirrhotic. So we can't rely on AST versus ALT ratio. But in the absence of cirrhosis, a ratio of 2 to 1 would be more in favor of alcohol etiology.
So the provisional diagnosis was alcoholic hepatitis with alcoholic cirrhosis in view of elevated enzymes, SGOT more than SGPT, with history of significant alcohol consumption till recently, and obvious changes of cirrhosis and decompensation on the ultrasound. But when we actually reviewed his past records, 10 days ago, his bilirubin was 9.5 with AST of 323 and ALT of 235 with an INR of 1.7. 20 days ago, his bilirubin was 2.5 with AST of 347, ALT of 298, and INR of 1.3. So this is what raised our antenna, because you don't expect transaminases more than 5 times, SGOT-PT more than 5 times in somebody with alcoholic hepatitis or alcoholic cirrhosis. So we were thinking now whether we are dealing with another acute insult which can cause such high enzymes. Common reason would be acute viral hepatitis, like hepatitis A, hepatitis E, or acute hepatitis B, or a flare of hepatitis B. So these would come to our mind immediately when you see high enzymes. But what is odd here? So what we are dealing with here now, it appears, is acute on chronic liver failure, because the patient has recent worsening. Then there appears to be an acute insult, which is high SGOT, SGPT. The next question is, how do we evaluate this? So we did HBsAg, we did NT-HCV, we did IgM anticore antibody for acute B, IgM HAV and IgM HEV, and both came, and all of these came negative. So we virtually ruled out any acute viral hepatitis. Of course, the still possibility of CMV hepatitis was there, but the clinical picture was not consistent with CMV hepatitis. The other thing why acute viral hepatitis was unlikely in this patient was that the transaminases were persistent for more than almost 2 weeks in the same range, and they were not really fluctuating much. Usually in acute viral hepatitis, in around 7 to 10 days, you expect the enzymes to peak, and then there is usually a steady decline. You'll start seeing change in the transaminases once the peak is achieved, and they keep on changing every day. So if you see 2 sets of reports, almost the same, more than 10 times elevated, 2 weeks apart, you should think that you may be dealing not with acute viral hepatitis, but something else. So it is always better to consider, it may still be autoimmune hepatitis, so it may still be acute viral hepatitis, it could be a camel hump pattern, or sometimes you do see unusually persistently high enzymes even in acute viral hepatitis, but your antenna must go up. So in this patient...
If I may just intervene here, there are questions here also. Number one is, you notice that, is there a cutoff value by which you say this is not likely to be alcoholic hepatitis in SGPT? The second question is, we notice a progressive decrease, however marginal it is, in the SGOT, SGPT level, but the INR has been going up. So which of these would be a more reliable parameter? And the third question is, what would be your criteria for calling it ACLF? So the first question is the cutoff for AST, ALT level before we say this is not likely to be alcohol.
So usually if the SGPT level are more than 5 times the upper limit of normal, we must think of another etiology. And SGOT more than 10 times, we must think of another etiology. It's extremely unlikely to be because of alcohol. The INR going up is actually an ominous sign. And if the INR has gone up beyond 1.5, it tells you that there is setting in of liver failure. Here in this patient, there is obviously cirrhosis, and the recent jaundice has worsened this liver injury, and that is why the patient has developed jaundice and decompensated in the form of ascites in a very short span of time, within 4 weeks. That is why we are calling it acute on chronic liver failure. That's the definition. So development of coagulopathy and or encephalopathy within 4 weeks of the onset of jaundice along with ascites is the definition for acute on chronic liver failure. Now, you always give far more importance to INR than transaminases. The transaminases will almost invariably fluctuate in most of these diseases, and in fact, in acute viral hepatitis, they would steadily come down. The INR going up tells me that the liver function is deteriorating, and it's a very important marker for liver failure. So we did further workup for etiology. Wilson's workup came back negative. ANA was negative, but anti-smooth muscle antibody was positive. So we went ahead and did a transjugular liver biopsy for this patient, which showed plenty of plasma cells, interface hepatitis, as we can see here, a lot of lymphocytes. So this was consistent with autoimmune hepatitis, and this patient actually we started on corticosteroids, and he did start improving. Of course, once encephalopathy sets in patients with autoimmune hepatitis, then steroids don't work. And this is something which we need to remember when we manage these patients. But in the presence of encephalopathy, we should not attempt to give steroids unless you are in a transplant center and you have transplant backup ready for the patient. What is new in alcoholic hepatitis? Because that is something which we will face more often. This was just to tell you that not all alcoholic hepatitis, alcoholics with hepatitis are alcoholic hepatitis.
Akash, yes, sir. Before you go to recent advances, when sir asked you that question of ACLF, can you elaborate for the audience? How do you differentiate between decompensation of a cirrhosis versus what you are calling ACLF? Because they may not be clear about these two terms.
So acute on chronic liver failure is a condition where the patient was till now having a liver disease which was well compensated. The liver was cirrhotic or advanced fibrosis, but it was still functionally good. Here, an acute insult happens, which makes the liver deteriorate very rapidly. Within 4 weeks, the patient of the starting of jaundice, the patient develops ascites and liver failure, which is diagnosed by coagulopathy, INR more than 1.5, or hepatic encephalopathy. Now, these acute insults could be anything. It could be the acute viral hepatitis, it could be a hepatotoxic drug, or anything else which has caused or sudden worsening of the infections, which have caused the sudden worsening of the liver function. In decompensation, what usually happens is, classical example is, as part of the natural history, the liver function has kept on decreasing, and at one point of time, it just starts decompensating. That means you start developing either ascites, GI bleed, hepatic encephalopathy, or jaundice. So these are the 4 decompensating events. So once any one of these 4 develop, you know that it is decompensation. When you see the whole syndrome, this whole clinical acute worsening with encephalopathy, with worsening coagulopathy, that is when you diagnose ACLF. So alcoholic hepatitis, we all know, we have been treating all these years with abstinence from alcohol, nutrition. Those are the 2 which have definitely shown benefit. In addition, we have used pentoxifylline very often for these patients, and several other drugs which are available, and I'll briefly allude to them. So now we know, after the STOPA trial, which showed that steroids are the only drugs which have some mortality benefit, but again very marginal. Only an additional benefit of 2 to 3% in terms of survival was seen in STOPA trial. And of course, you can give it only in biopsy-proven alcoholic hepatitis, and most patients are ineligible, basically because of either liver dysfunction, because of renal dysfunction, or infections, or severe sarcopenia. Liver transplant can be offered to a very selected few patients who are first-time offenders who have a very good social support system, do not have an underlying personality disorder. For them, severe alcoholic hepatitis, which is not responding to medical therapy, liver transplant can be offered. And the host of drugs which we are used to in alcoholic hepatitis treatment do not work when there is a severe alcoholic hepatitis. That is when what we call as DF more than 32, which is 4.6 into prothrombin time difference of the patient minus that of the control, and you add total serum bilirubin to it. So by this formula, you calculate DF, and if it is more than 32, you call it severe alcoholic hepatitis. In these patients, commonly used drugs like L-ornithine L-aspartate doesn't work, Silymarin, Ayurvedic drugs, S-adenosylmethionine, or ursodeoxycholic acid do not work. So glutathione does not work for this group of patients. It works for patients with mild diseases, or UDCA will work if the patient has severe cholestasis for amelioration of cholestasis. So our algorithm.
What about N-acetylcysteine?
So N-acetylcysteine is there is again mixed data. For patients who do not have infections, we can use IV N-acetylcysteine, but we have to accept the fact that it will predispose the patient to a higher risk of infections. So I would use it in somebody who is otherwise young, non-sarcopenic, and has a good otherwise general reserve. So in these patients, I would use IV NAC.
Okay.
And the dose would be like 150 milligram per kilogram for 24 hours as a continuous infusion for 5 days and never beyond 5 days.
Okay.
And terminate if there is any evidence of infection or renal dysfunction, because you can cause fluid overload with that. So our algorithm for alcoholic hepatitis is, does the patient have severe alcoholic hepatitis or no? If the patient doesn't have severe alcoholic hepatitis, then abstinence, nutritional support, and management of the portal hypertension. If the patient has severe alcoholic hepatitis, then you see whether the patient has any contraindication for steroids or not. Active GI bleeding, severe pancreatitis, uncontrolled diabetes, active infection, or renal dysfunction. If any one of these is present, then you cannot give corticosteroids to this patient. Then you have to straight away think whether he's a transplant candidate or not. If it is these contraindications are not there, then you have to use corticosteroids in biopsy-proven severe alcoholic hepatitis, and at the end of 7 days, or according to some of the most recent studies, day 4 and day 7, you assess whether the patient has responded or not by doing some calculations. If the patient has responded, then you continue for another 3 weeks and then taper off the steroids. Otherwise, this patient becomes a transplant candidate, and you consider this patient for LDLT. This patient will not be eligible for a cadaver transplant according to Mumbai rules. For those patients who are not candidates for transplant, they are repeat offenders, or they are having personality disorders, or the social support is not there, the patient is unlikely to remain abstinent from alcohol, which is actually a majority of the patients, then these patients should be given experimental therapy like either GCSF or fecal microbiota transplant, or other supportive and investigative therapies. So the learning points from this case: all alcoholics with liver disease may not be alcoholic liver disease. You may occasionally have another etiology. Transaminases are seldom more than 2 times upper limit of normal, but if you see more than 5 times SGPT and 10 times SGOT, think of alternative etiology. Autoimmune hepatitis is always diagnosed by liver biopsy. Please do not diagnose anybody without liver biopsy unless there is absolute contraindication. Biopsy-proven severe alcoholic hepatitis is best treated by steroids, but patients are rarely eligible for corticosteroids due to either hepatic encephalopathy, infection, sarcopenia, or renal dysfunction. Several drugs are available for alcoholic hepatitis therapy, but they are not useful for severe alcoholic hepatitis. Transplant and AFMT can be offered to selected patients with severe alcoholic hepatitis. So you would want to add anything?
No, I think it's a comprehensive review. There's a question from Dr. Josefa here saying, of course, it's only a question of interpretation. The first slide, you said that this patient has cirrhosis. So most of the discussion was on alcoholic hepatitis. This patient obviously has cirrhosis in addition, and that's a clinical situation we face so often, a combination of cirrhosis and hepatitis. So to extend the question, the drug that you talked about, the one drug that seems to make a difference, that is steroid, if there's no contraindication, will it work as well in a person with cirrhosis in addition to the hepatitis?
So it unfortunately it has not worked to the same extent in those without cirrhosis. So again, it will. So usually in somebody who has ACLF, you would desist from using corticosteroids because of the risk of infections. But if there is no other treatment option available, then you can consider it.
I'm done. Should we go to the next case or?
Yeah, we can go to the next case.
Sure. Perfect. So moving away from liver and coming into the lumen now. So 28-year-old lady, a business executive, complains of retroesternal burning for the last 1 year. This is associated with water brash and reflux. She has actual regurgitation of food which comes to the mouth, including sour reflux. There are no alarm symptoms. There is no history of NSAIDs. On first consultation with another physician, she was given pantoprazole 40 milligrams for 2 weeks. With that, she had a 50% improvement. So at this stage, what do you do next? Double the dose of PPI, add ranitidine or antacid, do an endoscopy, or add domperidone. So can we just have a vote? Professor Phadke and Professor Abraham.
Anirudh, want to take the first one?
Yeah. So, see, generally at 2 weeks, if there is 50% improvement, just to continue the same dose is a good option. I'm only concerned about her regurgitation. Suppose, especially if there is nocturnal regurgitation, there is a risk of aspiration. But otherwise, if she's at least 50% better, it is reasonable to just continue the same medication. Generally, my rule of thumb has been if the patient says 10% or less improvement after a week or 10 days, I increase the dose of PPI. And when we say 50%, we also need to know whether that regurgitation or water brash or food coming back in the mouth has stopped or not. Because in those who have very low lower esophageal sphincter pressures, the heartburn may decrease, but the regurgitation may not go. So if there is overall 50% improvement in everything, we can just continue because reflux often needs 8 to 12 weeks of treatment. But if there is less than 10% improvement, then the question comes of doubling the dose or doing an endoscopy to look for alternative diagnosis. And if there is no bloating in the stomach or no vomiting, generally I do not add any domperidone to these patients. So only PPI and lifestyle modification will take care of the reflux.
Sure. So I would agree with Anirudh. Of course, I always do. I don't have a choice. But two important points that Anirudh mentioned is that the treatment for GERD is generally longer than for the standard acid peptic disease. So we're talking about 8 weeks treatment. So if you have 50% response at 2 weeks, that's a good sign that the patient will continue to respond. The second point is about what are the components contributing to the GERD. So if these patients have symptoms suggestive of delayed gastric emptying, they are the ones that are most likely to benefit from a prokinetic. And that you would do in the beginning if you were suspecting that. One more point to remember is that prokinetics don't work on the esophagus or so much on the LES either. So it's important that we use them only in those who have a gastric dysmotility. The third point I want to add to what Dr. Phadke said is about the presence of regurgitation. Akash made it a point to talk about sour regurgitation. In any patient who's had symptoms for a year and no worsening, and it's been consistent right through for the year, and especially in a young girl like this, and 2 weeks therapy giving only 50% relief, we must in addition think of an esophageal motility disorder. because they can present with regurgitation from esophageal contents as well as heartburn as a consequence of stasis. So in these patients, of course, it's too early to think of that now, especially when there's a 50% improvement. But keep that in mind always, that all heartburn is not necessarily GERD.
Great. I can't agree more with both of you. So this patient then actually went to another doctor because it was only 50% improvement, and she, being a marketing executive, was not happy with 50% improvement. So this gentleman, this physician actually increased the dose of PPI to double dose PPI. And with that, she did feel better, almost 80 to 90% better. But again, in few weeks, the symptoms worsened, and she was back to where she was. So 80-90% improvement for around a month or so, and then back to where she was before the second consultation. So she did not come back to the original baseline, but where she was with single dose PPI. So at this stage, and to answer Professor Abraham's question, her reflux symptoms had actually gone away. The only thing that was persistent now was still occasional heartburn. So would you add now domperidone or shift from pantoprazole to another PPI like reviprazole or esomeprazole, or add ranitidine or antacid at night time? Or now you would want to do an endoscopy to rule out a hiatus hernia or Barrett's? Dr. Farke, you would want to take this?
Yeah, so if we assume that she has taken 8 weeks of PPI and there is still, 10-15% symptoms are still persistent, then it is reasonable to do an endoscopy at this point of time to see what is the anatomy. As well as, although Barrett is not very common at 28 years, still it is possible that she had long time reflux without realizing. Most of the reflux patients, for some reason, I end up giving them esomeprazole. And I have this strange feeling that it works better in reflux as compared to pantoprazole. I'm not sure about rabeprazole, but this is completely, individual opinion. That many patients who have not responded to pantoprazole do respond very well to esomeprazole. So,
Sir,
yeah.
Sorry, I'll just interrupt here. I would want this important question here. So, what about pantoprazole 80 milligrams? Because that has been shown to have better outcome than 40 milligrams in reflux disease as well as for acid peptic disease. So, where do you place that in your algorithm?
No, I have not used 80 milligram because, there is a difference between every time a new formulation comes, there is always some data which says that it is better than the previous one. So that is the game. That's a different thing. But changing the PPI and doing an endoscopy basically to find out whether there are erosions, whether there is hiatus. So I would do an endoscopy and switch the PPI.
Sure. Professor Abraham?
Yeah, I would agree once again with Anirudh. About changing the PPI, no question. And I thought I was the only slow learner in this city because I always wait to see the response to a new drug in others' experience before I change. So,
I think we have we lost, sir? Sir's network has gone?
Looks like.
Yeah. So hopefully sir will join. So, but I agree that we need to, usually we would also change the PPI. I cannot say that 80 milligram doesn't work better because I was part of that study. We had recruited almost 55 patients in that study. And we did do pH metry for that group of patients. And on pH metry, so it was not just soft endpoints like symptoms, but actually on pH metry, there was a significant improvement. So hopefully sir will join us back in some time. So this patient did undergo an endoscopy and it was an absolutely normal endoscopy at this stage. This
Now
patient
here,
then...
Akash, I have a question for you. For reflux patients, especially young patients, should you do endoscopies under sedation? Because retching completely changes your finding of hiatus hernia.
Yeah. So yes, sir, I agree with you. Very often I would be, in fact, I prefer to do my endoscopies under sedation for multiple reasons. One is I get enough time to evaluate. I'm never in a hurry. So to look at the small lesions and to look at the Z line, to look at reflux. So not only for reflux, but for almost all my patients, I prefer to give a conscious sedation, so TIVA, rather than giving a full anesthesia. So they become awake and they come out of it on table itself. So it is pretty safe. And I think that is what has improved the outcomes of endoscopy, because I can spend 10-15 minutes looking at each part of the stomach, looking at the Z line, looking at Barrett's esophagus, taking meticulous biopsies when required, rather than patient retching and assistants holding the patient, and I'm trying to finish off the endoscopy quickly before he coughs out. And especially now in COVID, I think this is can't be emphasized more.
Yeah.
So third consultation, a prokinetic was added, and as expected, like both of you have already said. Oh, sir is back. Welcome back, sir. We have just gone ahead. We did an endoscopy, and that is normal. And a third consultation where prokinetic was added, and as expected, it did not give any relief because this patient had mainly heartburn and no longer any evidence of bland regurgitation or volume reflux or gastroparesis. So a fourth consultation was sought, and a nighttime H2RA was added at that time, which still did not improve the symptoms. The patient was anxious, still complaining of some reflux symptoms in the form of heartburn mainly now, but not actual regurgitation of food. So at this stage, we had the following options: either add alprazolam, because this is when the patient has come to us, shift to rabeprazole, domperidone twice a day, or refer for surgery because this is like a refractory GRD. So patient was anxious, so adding alprazolam is a good option, but I don't think it takes away the problem that she is having. And alprazolam in a young person has got its own problems, especially if you're giving for prolonged period of time. Benzodiazepine agonists actually will hamper the immediate registration of new information. So their cognitive ability actually goes down. So I would be very reluctant to add alprazolam. Shifting to a drug combination like rabeprazole plus domperidone would not benefit because one prokinetic has failed here already. And especially when we use fixed dose combinations, this combination already has 30 milligrams of domperidone. So when you give this combination twice a day, you actually tend to overdose domperidone, and that can have side effects. A domperidone dose of 60 milligram or more is associated with sudden cardiac deaths in elderly and in those patients with chronic kidney disease. So in those two populations, you have to be very careful about the dose of domperidone and never exceed 30 milligrams. So
Akash,
this patient
also there is risk of galactorrhea in women. That's one more thing to consider.
Yes, absolutely. So in women, galactorrhea and even extrapyramidal side effects can take place with these prokinetics when given for long period of time. When you think of surgery, surgery doesn't work for those patients who have not improved with PPI, because these patients may have additional pathophysiology. Most patients who actually respond to PPI or have a significant response to PPI, but do not want to continue drugs, those are actually the candidates for reflux surgery. Cardiac evaluation in a 28-year-old, yes, you may think of clinically, but I don't think you'll seriously consider it as the etiology here. Heartburn going on for more than 1.5 years. I don't think you're dealing with a cardiac disease here at all. Would you do a 24-hour pH-metry? Probably yes, because now you want to really know whether the symptoms are because of reflux, GRD, or there is something else. So this patient was planned for a 24-hour pH-metry with impedance, which is basically a catheter is placed in the esophagus, and you keep on recording the pH at multiple places in the stomach and the esophagus. And you also, by adding impedance, you measure what is the type of reflux, whether it is solid, liquid, or gas. So that is what was done here. And to explain the result, Demister score was 15.5. Now, a value of above 14.5 suggests reflux disease. But the key thing here is this is just above what is normal. So it is not a significant reflux disease which should not go away with PPI. So there has to be something else. A mildly elevated Demister score does not strongly suggest GERD, which is refractory. The acid exposure time was marginally elevated, just 9% as compared to 6. What was important was every time there was an acid exposure, it had excellent symptom correlation. So 80% of the times, the symptoms happened when there was a mild acid exposure in the esophagus. So when you look at the reflux symptom association probability, now forget the jargon, just concentrate on this lowermost graph. Whenever the patient had heartburn, actually the patient had a physiological acid exposure of the esophagus. So it was not the excessive acid coming up, but that some amount of acid which comes up normally, that is what was triggering the heartburn symptoms in this patient. So the diagnosis was actually a hypersensitive esophagus. So this patient started off with a GERD. That is why she responded significantly to a PPI, but the persistent symptoms were because of a hypersensitive esophagus. And therefore, the treatment for this would be on the lines of hypersensitive esophagus. So the few questions which we need to know about the PPIs is, one, is there a particular timing for consumption of PPI? Professor Abraham, if you can take that.
Okay, I probably missed. I mean, I did miss out because of technical failure. A timing of consumption of the PPI, the first generation PPI, that is omeprazole, pantoprazole, and lansoprazole, there's enough evidence to say that we have to take it prior to meals. But with the second generation PPI, that is rabeprazole and esomeprazole, we have data to say that even if you take it after meal, you will get the same effect. So timing in relation to meal is not as important with the second generation PPI as it is with the first. But as a rule of thumb, we would recommend that all patients take it before meal, half an hour to 1 hour before meals.
Yeah, the second issue we have already addressed, the PPI plus prokinetic fixed dose combinations. So prokinetics to be added only if there is volume reflux or if the patient has features of delayed gastric emptying, which is contributing to the reflux. And we discussed the problems of prokinetics as well. We did discuss role of impedance pH because it will tell you what is the type of reflux that is happening. And Dr. Abraham briefly alluded to the esophageal manometry in GERD. So Dr. Farke, how interested are you in knowing the LES pressure or esophageal motility in these patients? And Dr. Abraham did mention about the esophageal disorders.
Yeah, so it is important in patients who are not responding. And secondly, in a patient who is responding, but you are considering surgery. See, a 28-year-old patient, very lax lower esophageal sphincter causing recurrent erosive esophagitis. Patient is concerned about side effects of taking PPIs for many, many years. So generally, a patient who responds to PPI but does not want to take PPI, or who responds to PPI but has volume reflux, they are the candidates for surgery. And pre-operative, it is mandatory to do a manometry, check LES pressure, check the esophageal motility, because that may decide, that may help your final decision about the surgery as well as type of surgery that is done.
Yeah.
Yeah, so if I could extend, I mean, apart from the fact, Aniruddha said it so clearly, but apart from the fact that we would sometimes miss out an esophageal motility disorder presenting with heartburn, if you look at the various components of GERD, what's important about doing a manometry prior to surgery? If a patient has a good LES tone and has poor esophageal body motility, he would not be the optimal patient for a surgery. or if the patient has gastric emptying disorder, which is contributing to his reflux disease, then tightening the sphincter is not the only answer, because they'll in fact have even worse symptoms. They'll have difficulty in burping out the contents once you tighten the LES. So although many surgeons now go in for surgery without the benefit of a manometry because they're so confident of their results, ideally, Dr. Phadke, what Dr. Phadke said is the answer. You should have a manometry prior to doing a surgery.
So, comparing the few things about the PPIs, Dr. Abraham has already spoken about. We discussed the pantoprazole 80 milligrams and the advantage of 80 milligrams. The key thing which I want to bring about here or highlight is that when you look at the metabolism of these PPIs, all drugs except for reviprazole have a CYP2C19 based metabolism or CYP3A4 based metabolism. So there is enzymatic pathways, whereas reviprazole has non-enzymatic pathway. And that is why when you have a co-prescription with other medications which affect the CYP2C19 or CYP3A4, especially clopidogrel, phenytoin, diazepam, theophylline, or warfarin, or tacrolimus, you would almost always prefer reviprazole, or you can prefer reviprazole over other PPIs. So learning points from this case, rational approach to PPIs, rather than blindly increasing the dose, appropriate dose for the appropriate patient. Use prokinetics only where it is necessary. Hypersensitive esophagus is not uncommon and should be kept in mind, especially when there is some partial response to PPIs. Endoscopic or surgical intervention should not be offered to those with non-response to PPI, but those who have response but do not want to continue PPI or who have volume reflux on PPIs. Most GR or GR-like problems can be solved with medical therapy and right clinical approach, and beware of these drug-drug interactions of the PPIs. Sir, any audience
questions? Yeah, there are questions here. Dr. Seth has asked the question, what would have been the diagnosis? Now, you talked about a good correlation between symptoms and acid exposure in this patient. If there was no good correlation between the acid exposure and the symptoms, what would have been the diagnosis? And what would have been the diagnosis and your management plan? So if I could extend the hypersensitive esophagus that you talked about, where we have acid reflux, but not at the level that we would expect symptoms, we would call that a hypersensitive esophagus. There's the other entity of functional chest pain or functional heartburn, where there isn't any acid reflux, but still the patient presents with heartburn. So maybe that's a condition that we should talk about when we talk about if there is no correlation, then what would be your diagnosis?
Yes, sir. So actually, when there is no correlation, that is what is called as functional heartburn. And I think that is a more difficult entity to treat than a hypersensitive esophagus. So
there's two questions, one from Sangli and the other from Mumbai. Dr. Patil from Sangli, both of them asking the same question. How long can we safely give PPI, and is there a risk associated with that?
So the PPIs are usually safe, much safer than most other drugs, but it is not that nobody will ever have a side effect. Most patients who take PPIs over 20 years or more, around 1% or less than that can have adverse events. And the ones which we are mainly worried about are the renal dysfunction or the bone disorder, so the osteopenia. So I think those are the two side effects which you are worried about. The key thing here is always try to minimize the dose of PPIs and try to taper off and stop PPIs whenever possible. But in those patients who continue to have symptoms which responds only to PPI, do not be afraid to continue the PPI, because the risks associated with stopping the PPI will be more than the benefits that you get by stopping the PPIs, or the side effects that you avoid by stopping the PPI. So where indicated, please feel free to use it over long periods of time, but try to reduce the dose and attempt to stop wherever possible.
So maybe say then that the young adult with no comorbidities and no risk factors can take it for a long time, but the elderly with sarcopenia, osteopenia, or those who have renal dysfunction, you should be a little more careful, or those who have unusual exposure to unhygienic circumstances, or have micronutrient deficiencies, would these be people where we would be a little more careful? But for the general population, the fear is not there.
Sir, I would in fact put it this way. If it is indicated, then I think we should not be afraid to use it.
Even in the elderly who have little bones?
Yes. But wherever it is not indicated, we should definitely not use it.
No question.
More so in the elderly or this. So if there is a soft indication, like when we give as a co-prescription, I would be very careful before routinely prescribing it as a co-prescription. When we are using it for somebody who has a heartburn or non-ulcer dyspepsia or epigastric burning, I would not be reluctant to use. But again, the minimum dose. I would be more careful when it is being given empirically or as a preventive thing. That is where in elderly or those with sarcopenia or nutrient deficiencies or critically ill, I would be very reluctant.
Because Akash is young, but after the arrival of PPI, have you noticed that every other drug needs an anti-acid therapy added?
The problem.
So co-prescription is easily the most misused indication for PPI, isn't it? Before they came, these drugs didn't seem to cause, the other drugs didn't seem to cause acidity. But now every drug causes acidity and needs a PPI.
So, sir, it is a co-prescription, that is one aspect, but irrational first prescription is also very rampant.
Yes.
Because even patients of acute viral hepatitis or acute gastroenteritis, those who vomit are given pantoprazole intravenously.
Absolutely. There's no symptom analysis because of the safety of these drugs.
Yeah. And secondly, if this patient takes 4 weeks of pantoprazole and then he stops, he gets rebound hyperacidity. So the patient on his own goes to the chemist and buys it again.
Yeah.
And lastly, it is the, patients give a diagnosis. If they have headache, they say, I have acidity problem. And, over the counter, all PPIs are available.
True. So there's one more question.
I would agree with that. I would agree.
Absolutely. Yeah, absolute truths these are. Akash, there's one more question from Dr. Bange in Hyderabad, which is a very relevant question because we didn't talk about that. Why not take esophageal biopsies to rule out eosinophilic esophagitis?
Yes. So in patients who have refractory heartburn or unexplained dysphagia, or if you find corrugated esophagus on endoscopy, or if you find linear ulcerations, we would almost always take mid-esophageal biopsies for these patients. Although when we did a study, prospective study in KEM hospital, we looked at 136 consecutive patients with heartburn which was not responding to PPI, and we did take mid-esophageal biopsies, and we didn't find any patient. The only one patient whom we diagnosed eosinophilic esophagitis was actually having systemic eosinophilia and hypereosinophilic syndrome. So it is uncommon in at least our setup.
Rare, maybe.
So it's rare. But yes, it is a good thought, and we should keep in mind in such patients.
So should we move to the next case? We have 2 more to go.
Yes, sir.
All right.
This is 4th. So 62-year-old lady, symptomatic for last 2 years, complains of incomplete stool evacuation. She has history of excessive straining. The stools are hard, and she has occasional finger evacuation as well. There are no red flag symptoms, so no bleeding, no anorexia, no weight loss, no tenesmus. She has a history of hypertension, and she is on amlodipine for last 10 years. Examination is pretty normal. Other systems are pretty okay. So at this stage, what are the options? Will you start laxatives? Will we do a stool occult blood, do a colonoscopy, or do none of the above, or something else? So just a quick answer. Professor Phadke, what would you do at this stage?
Yeah, I would start the patient on some laxative because obviously she has come for symptom relief. But in every patient with constipation, we do a blood count, we do a stool occult blood, we check thyroid, we check calcium. So these are the common things, systemic disease presenting as constipation. And because she's 62-year-old with change in bowel habits, she merits a colonoscopy. It may not be immediate, but at some point of time, she's going to need a colonoscopy.
Okay. So a PR examination is done. The inspection is normal. Palpation is non-tender. Normal descent, normal tone and squeeze. No blood at the fingertip. So, what are the possibilities, Professor Abraham? Are we dealing with normal transit chronic constipation, or dyssynergic defecation, or slow transit constipation, or it could still be an organic colonic pathology like malignancy? So, how do you develop this algorithm clinically?
All right. So I agree, of course, with Dr. Phadke about the age of onset and how recent are the symptoms. So if it's an elderly patient above the age of, there's no cutoff, but above the age of 50, I would say 60 is what most Western guidelines say. But above the age of 50 and a recent onset, again, few weeks or 1 or 2 months, you have to, and if there's other alarm features, you must look for, get a colonoscopy to rule out an organic disease. Now, when it comes to the type of constipation, I do a symptom analysis. If this were a longer standing history, let's say 2 years, and the person
Yeah,
was
2 years.
30 years old, I'm sorry?
Yeah, this is 2 years history.
2 years history, and in a young person, let's say a 30-year-old person, where we are not suspecting any organic disease, I would then ask the patient, what are your symptoms? When you say you are constipated, like this patient has incomplete evacuation. So by constipation, do you mean that the stools comes there, but you can't get it out? You need to strain, you sometimes need to put a finger inside, then this is an evacuation disorder. If I get the urge, but my stools are not completely going out, it's probably a normal transit constipation. If I don't get the urge, I just feel bloated all the time, and it's only once in 2 or 3 days that I can actually get a good motion, then that's likely to be a slow transit constipation. So a symptom analysis is very important. And in this case, she has all the features to suggest an evacuation disorder, except for the age, where you must rule out an organic pathology.
Yeah, so I completely agree, sir, with you. This is how usually we would clinically, we have learned from you only this approach. So the symptoms themselves almost always will tell you what you're going to find on investigations. So investigations are just a confirmation of what you have thought clinically. Why this is important? Because the treatment of each of these is slightly different from each other. Your choice of laxative would vary, and of course your whether you need a specific therapy like biofeedback or not will depend on whether you have dyssynergic defecation or not. So this patient, like Dr. Farke said, we did do the systemic investigations, which came back normal. Colonoscopy was done, which was normal. Amlodipine was changed to telmisartan, thinking that amlodipine, being a calcium channel blocker, could contribute to some extent, although the patient did not improve much after shifting to telmisartan. Patient was started on soluble fibers, did not have any improvement after 4 weeks. One of the reasons is our Indian diet anyway is rich in fibers, and therefore, very often by just adding fibers, you won't get much benefit. The type of people whom I add fiber today is those who have more of a Western sort of diet, with a lot of maida-based products in their diet, rather than having the traditional Indian food. So at this stage, what would be your choice of laxatives, sir? So would you use lactulose, PEG, isabgol, procalopride? How do you choose which patient will benefit from which laxative?
So, like I said, if the patient doesn't find the stool, you'll find quite often that these patients have soft stools. It's not hard. The stools are there, but they can't get it out. So this would naturally mean that there is a rectal dysfunction. So just softening the stools is not likely to help. Like you mentioned, if these patients are already on adequate fibers, adding more soluble fibers may not help. Though, of course, a supplementation of a fiber dose is the first thing that we would do in any case, provided these are not slow transit constipation. If they are slow transit constipation, then lactulose, lactitol, fibers will add to their discomfort. But for evacuation disorders, yes, I do give it. Sorry, go ahead.
To interrupt, to just highlight this point. Uh, when a patient has constipation and bloating along with it, that is when lactulose and fibers are actually sometimes counterproductive, because they themselves can add to the gas formation, because they do contribute to that, and their patients may actually be more miserable than better, especially if there is a defecatory disorder and not really a chronic slow transit constipation. So I think this is a very important point which Professor Abraham has brought out, which I thought everybody should understand. So please.
So as far as the choice of laxatives is concerned, we don't have a specific evacuation disorder laxative. So we're back to using the other laxatives that are used as common laxatives. My experience with levosulpiride, for some reason, I prefer to use that in the initial days, but it's not always so satisfactory. I have even tried levosulpiride, and that has not been very. I'm talking about
Citalopram.
no, lubiprostone and levosulpiride, two drugs that I use. I don't know if I used wrong names initially, but lubiprostone and levosulpiride are two drugs that I have used in the hope that they would not be true laxatives, but just would help to overcome the rectal insensitivity. But the results have not been always so promising. So then the choice is between procalopride or sodium picosulfate.
Or polyethylene glycol.
Or polyethylene glycol if the stools are hard.
Yeah, so basically polyethylene glycol as a stool softener and making the stools easy to come out, and procalopride mainly to stimulate the colonic motility. So I think that is where, depending on whether it is slow transit constipation or normal transit constipation, you would decide.
So Akash, here one small point is polyethylene glycol is a very good, very effective laxative. The problem is that product insert says that it cannot be used for more than 30 days.
So true.
And this is what the patients are upset about, because we tell them, no, you can use it, it is safe. And the product insert says that it cannot be used beyond 30 days. So probably the product insert says that because uninvestigated constipation, people will keep on taking this rather than somebody with alarm symptoms going for a colonoscopy or any other medical investigation. But I'm not sure why it is there. It was shown to me by one of my patients, and then I realized that.
Yes, and if you go on the net, you'll find that PEG has a bad name on the net because it's an industrial chemical product. So they say, and there's enough articles to say that it is toxic, enough medical and non-medical articles. So patients come up with all that literature. But we have data saying that up to a year, there's no safety issue. Yeah. So I don't know why the product literature still says that.
So what will you do next for this patient? Will you do a colonic transit time study, anorectal manometry, MRI defecography, or you would increase the dose and frequency of laxatives? Sorry.
Okay. So if you have to evaluate a patient with constipation in general, the first test that we would normally do is an anorectal manometry if we have to investigate. Why am I saying that? Because although we have so many years or decades of experience with manometry, as an old man now, I'm not sure these things really add on to clinical judgment. But if we have to investigate them, the first thing would be anorectal manometry. In this patient specifically, since these symptoms are all suggestive of improper rectal function or dysfunction, if you want to call it, anorectal manometry would be the most specific investigation as first line. Colonic transit study is only when we want to differentiate normal transit from slow transit constipation, which we talked about earlier. I would do an MR defecography only if I suspect that there's a rectal prolapse or an internal prolapse or a rectocele formation or where I plan a surgery. As a routine, I wouldn't go for an MR defecography.
Sir, I would want to ask this question to both of you, whosoever wants to take this up. When is it that you clinically suspect that there could be an internal prolapse based on what symptoms, and that you may be dealing with a surgically correctable problem rather than a medically correctable problem?
Let me answer that in a simple term. I have never sent a patient with dysfunction for surgery. And I know centers that do it quite regularly also. So either I'm missing out something or they're picking up something. Anirudh can be more wise in his answer.
No, what you say is correct, because most of the centers will do surgery without doing a colonic transit. And I have seen worse outcomes after surgery.
Yeah.
So, logically, ideally, if you ask me, every difficult to treat patient needs a detailed workup. There is no doubt about that. The issue is again whether you follow option D first or not. Whether you keep on changing them, because I always tell patients, if A plus B is not working, it doesn't mean C plus D will not work. So there are 5-6 laxatives, and it is a kind of jugglery, or you can call it trial and error to hit the best combination for a patient. When do I do all these investigations? Number one, young patient, very unusual symptoms. Number two is you have tried different laxative regimens and just there is no response at all, or patient who says patient has obvious rectal prolapse. There is digital evacuation, and that again is one thing that almost always you will find some abnormality on MR difficography. So difficult to treat SRUS patients, difficult to treat patients who are not responding to, I changed laxative 2-3 times and there is still no response. And they have excessive straining in their toilet time is sometimes 30 minutes, 45 minutes. They can read all newspapers together in one sitting. So those are the patients who are almost certainly going to benefit. Now, there is also some literature we say that no urge means transit time problem. But majority of patients will have mixed problems. They will have some decreased transit as well as this. And there is also some data which says that if you have defecatory disorder or dyssynergy, transit times will worsen. Okay, so if you correct the dyssynergy, the transit times also improve. So there are some studies which say that. So practical problems are the availability of the tests in one center, everything. Second is the cost. And third is when we come to treatment, even if everybody says biofeedback works, it is not practical for patient to go so often to other end of the city and get the biofeedback done. So ideal setting, if I have everything available, low cost, I will do everything for difficult to treat constipation. But finally, if you ask so many tests for the patient says, I might as well take Kayam Churan and be happy with that. So for the patient, what is important is not the pathophysiology. Finally, they should find relief in the symptom.
But having said that, Anirudh, there are some patients who will feel better once you show them an abnormal motility, isn't it? So yeah. It's a very important point that you mentioned about biofeedback, because prior to biofeedback, you must have recordings, because biofeedback is ultimately based on showing them improvement in the recordings. Some patients do feel better when they think that the doctor now knows what he is treating. Yeah. One more point that I wanted to add to this is about telling them about rectal sensitivity. That if they can control the urge to go to the washroom, because they know that most of the times when they're going there, it's an unproductive visit for them. Like you said, they could finish reading the newspapers, and many of them install TV monitors inside. So if we can advise them and convince them to avoid doing that, and tell them also that every time they put a finger inside, they're making the situation worse by increasing rectal sensitivity. It's very difficult. I mean, patients don't do it because they enjoy it. They do it because they don't seem to have a choice, or nothing else seems to relieve them. But if you can convince them to stay off that, maybe we can break this cycle somewhere.
Yeah. So I think we have confused our audience enough. So let us now try to solve the confusion that is there. So this patient, we did an anorectal manometry because we wanted to know whether the problem is in the coming out of the stools, or whether the coming out of the stool is normal, but there's a problem in the stools moving from right side of the colon to the rectum. That is the first clinical question which we have to answer. So anorectal manometry we did, where when we asked the patient to strain, we can see that the rectal pressure, when it went up, that is when the patient actually attempted to defecate, the patient has also paradoxically contracted the anal sphincter. This is what we call as type 1 defecatory disorder. So here is a patient whose stools are there in the rectum. He is attempting to pass these stools from below, but without realizing, she is paradoxically contracting the the anal sphincter. So this is where the stool are already there, but not coming out. You classify the defecative disorders into 4 types based on these manometry findings. Why it is important? Because the type of exercises that you teach to these patients will depend on what is the pattern on anorectal manometry. So here you need to teach the patient how to actually relax the sphincter when they are defecating. So it is almost like toilet training once again, unlearning what they are doing and then teach them to do it the right way again. So in simple words, the other test which we did was the balloon expulsion test, which was around 2 minutes in this patient. So what is this balloon expulsion test? We inflate a balloon in the rectum and we ask the patient to expel it out. Of course, it is attached to a catheter which is hanging outside. So if the patient can't expel it, we can just pull it out. So the patient should be able to expel it out in 60 seconds. If the patient is not able to expel it out in 60 seconds, it tells you that the patient has a dyssynergic defecation. That is, the coordination of the rectum and the external ileal sphincter is gone, and that is why the patient is not able to expel out a balloon. So here, the problem is not in the transit of the stools in the colon, but actually the stools coming out of the rectum. We have been talking about slow transit or normal transit constipation. So we do something called as colonic transit time study to find out if the motility of the colon, the ability of the colon to transfer the stool from the right side of the colon to the rectosigmoid is normal or not. So typically you divide you give the patient barium pellets. There are different protocols. We have our own protocol, which was devised and validated on local population in KEM hospital. Sir was the head of the department at that time when this was validated. And after ingestion, then you take X-rays and you see how many markers are there in which part of the abdomen. In somebody who has normal motility, most of the pellets would have been expelled out with the stools. If you see pellets being retained, then you want to know whether they are being retained on the right side of the abdomen or in the rectosigmoid. If they are being retained more on the right side of the abdomen, then you know that you are dealing with a colonic hypomotility disorder. And where the choice of drug would probably be something which will stimulate the colonic motility and make the stools liquid, both. If you have majority of these markers in the rectosigmoid, that is in the left lower quadrant, then we know that we are dealing with a defecatory disorder or evacuation disorder. The colonic motility appears to be normal. So the pellets have reached in the rectosigmoid but are not being expelled out. So we had actually, and this is also a very important way to identify those patients who are malingering. Because when you have patients who come and say, I didn't pass stools for last 3 days, and you see that the barium markers are all gone, then you know that he has obviously defecated them out. So this is also something which helps you. So in a slow transit constipation, typically this is how you'll get a lot of markers on the right side, some markers on the left, and some markers in the rectosigmoid area also. So our patient, we gave 8 sessions of biofeedback therapy. So what is this biofeedback therapy? So the traditional way of giving biofeedback is we show them the manometry recording, when they're doing wrong, and then keep on training them while the catheter is still in there so that they see that what is the right step of straining or bearing down. What we have learned in KEM over a period of last 7 to 8 years is actually we teach them those exercises of defecation. Simple things like when they are actually straining, when they are sitting in this for the stools, how to keep the back straight, how to ensure that the tummy is actually going out and not going in when they're attempting to defecate, and those simple exercises which can be taught depending on what is the type of defecatory disorder. And with that, most of the patients actually respond. So in this patient, after 8 sessions of those exercises given by a trained physiotherapist, we actually found that there was a significant improvement and the patient's symptoms improved completely in 8 sessions over around 3 months period. So I think we discussed most of these points. sir, are there any audience questions or any comments at this stage?
So far, we haven't received any questions on this subject. But
so Akash, my question is, does biofeedback work without laxative?
So, sir, we would almost always give laxative to start off for the initial symptom relief. Here, this patient had a combination of both slow transit constipation as well as defecated disorder, which is what you said is very common, having a combination of the two. So here we gave laxative as well as biofeedback, and the patient improved. I think when they actually take biofeedback, their colonic motility does improve and the requirement and their of laxatives go down, and they also start feeling better and they feel more in command because they have now learned to defecate properly. That frustration, that irritability which is there throughout the day in patients who are unable to defecate satisfactorily in the morning, that somehow tends to come down in these patients.
So Akash, before we move to the next question, next case, the last case, I believe, we have a question from Dr. Rakesh Patel. He's a gastroenterologist from Ambernath. Do all of us know him? I think the world knows him. Yeah, the world knows him. So he should be answering this question. I wish he were on the panel, but he's asked a good question. Patients who do not respond to double dose PPI and have erosive esophagitis, what do you do for them?
So, sir, I think this is a classical case of either the non-compliance with PPIs, or there is a volume reflux with non-acid reflux.
No, but they have erosive esophagitis.
Yeah, so even you can have erosive esophagitis with
bile reflux.
Refluxers. Yes, sir. So in these patients, I would almost always do an impedance pH on PPI to see whether they have sufficient acid control or not. And very often, what we find is they are they're extensive metabolizers of PPIs, and therefore they do not have sufficient pH control. These patients, I would put on Reviprazole and try.
Yeah. So if
would you do serum gastrin also in this patient? These patients.
Yes, sir. So, yeah. So that is the second thing. So if you are thinking of Zollinger Ellison or an acid producing tumor, then yes, for sure we will do so.
If I have to extend Rakesh's question, if this patient has adequate acid suppression on double dose PPI and still has erosion, so we know it is acid suppression done, no volume regurg on impedance, and the erosions are still there, so it's not a hypersensitive esophagus, would these patients then benefit from surgery? Would you be able to bring down the dose of PPI?
I think these are the patients who will actually benefit from.
So it's an exception to the rule saying that a good responder is a good candidate for surgery.
So here it's achieving a good acid suppression, but the lesions are not healing.
Yes.
So that is why I think
it's a trade-off. You can't keep increasing the dose of PPI. You have to bring it down. So maybe addition of surgery would help them.
Yes, I think so.
Yeah. Especially if they have.
Pathology has to be some amount of reflux, which may not be as per our definition of the criteria.
So exceptions, yes. Yeah. It's not as per the rule book, but yes. So we have only 10 minutes left now.
Yes, sir.
Before everyone falls asleep.
Right. So I'll quickly take this case. 46-year-old gentleman, alcoholic cirrhosis, was admitted for the first time in January 2017 with ascites, CTP of 9, MELD of 11, portal hypertension, ascitic fluid showing 200 cells, high protein, low protein, high seg ascites, was treated with diuretics, 1 tablet of furosemide plus spironolactone and salt-restricted diet with initial response. However, he was non-compliant with salt-restricted diet and continued to have alcohol. So he presented with ascites around 2 months later with umbilical hernia and left-sided hydrocele. So imaging was done, which confirmed that this was umbilical hernia with fluid and normal bowel within and an uncomplicated actually fluid accumulation in the scrotal sac. So at this stage, abstinence was re-emphasized, salt-restricted diet was confirmed and ensured. The diuretics were stepped up to 2 tablets a day. and he was called again after 1 week with renal functions. He was doing well for a month, but then he had worsening of ascites. At this stage, salt compliance was confirmed. Blood pressure was 96/52, no postural drop. Tapping was done of around 7 liters with 40 grams of albumin given, and subsequently the diuretics were stepped up to 220, so 4 tablets of spironolactone plus furosemide a day. The creatinine at this stage was still normal. The ascites improved, but his blood pressure was 88/50, and there was a worry. By the time we could react to that, patient presented with obstructed umbilical hernia, and had to be operated immediately. These patients are very difficult to manage post-operatively. The drain keeps on coming out. It is very difficult to control the drain output, and they have a high risk of infections and secondary liver failure. Fortunately for us, this patient with continuous albumin therapy, diuretics, and noradrenaline, we could keep him stable. And after 10 days, the patient was actually discharged. For next 3 months, every 15 to 20 days, he required a tapping. His evaluation was done for refractory ascites, 2D echo. Blood pressure was still low, 86/52. He was not on beta blockers. There was still no postural drop, so patient was euvolemic at this stage. Creatinine was 1.1. Sodium was on the lower side, 126, but still manageable. Potassium was 4.3. Uh, so, first question: this patient has a consistently low blood pressures, but normal creatinine, sodium, potassium. So, is there a cutoff of mean arterial pressure that you have, or acceptable blood pressure for increasing the diuretics? The textbooks usually will mention that mean arterial pressure of 70 or less would mean that you should not give diuretics. In fact, that is an indication to stop the diuretics. Or a systolic blood pressure of 90 or lower would entail you to stop the diuretics. So in real life, what is the acceptable map that you chase, or a systolic or diastolic cutoff that you have in practice? So
that's a question to us, Akash.
yes, sir. So what do you usually do? Do you have a cutoff in your practice, or you go by creatinine and general clinical assessment?
Yes, I don't use a cutoff. It all depends on how well the patient sustains himself or can tolerate diuretics. But if there is a progressive drop in BP, yes, of course, we would not use a diuretic. But I don't use a cutoff in clinical practice.
So the worry about lower blood pressure is these patients may be having impaired renal perfusion, and that is why, although they are able to excrete the creatinine, the GFR has actually come down. So they are maintaining their creatinine by over excreting creatinine in the tubules, but their glomerular filtration rate is actually lower down. That is actually low. So that is why it is not a good idea to continue diuretics even if they have a normal creatinine if the mean arterial pressures are low. And that is why either we give something to increase the mean arterial pressure for these patients, or we reduce the diuretics depending on the clinical condition. That is what I would do in my practice.
Would you want to add a line about creatinine and liver disease?
So yes, sir. So in fact, creatinine can be very misleading in patients with liver disease, especially cirrhosis. It tends to really overestimate the renal function. So a creatinine of 1.2 or 1.3 in somebody without any liver disease, you will pass it off as normal. But in somebody who has got low muscle mass, sarcopenic, in that patient, even a creatinine value of 0.8 or 0.9 sometimes will be considered abnormal. So for us, whatever has been the nadir, the lowest value, just 0.3 above it is the upper limit of threshold for considering it as abnormal. So if the patient has always had a creatinine value of 0.5, then any value above 0.8 should be considered as significantly abnormal. So at this stage, when you have low mean arterial pressures, patient still has ascites, this would be one of the indications to add vasoconstrictors. Uh, we use urinary sodium now more for ensuring that the patient is compliant with the salt-restricted diet more than anything else. The other place where we do urinary sodium is to assess whether somebody is going to respond to diuretics. So in a hospital setting, we can give one dose of furosemide and look at the urinary sodium. If the urinary sodium increases significantly, almost 4 times the baseline, then we know this patient is going to respond to diuretics. So it is useful in those patients who have difficult to control ascites in some selected population, but not in everybody. So the question comes, how do we proceed in our patient? Alcoholic cirrhosis, decompensated, significant ascites, difficult to control, low blood pressures, requiring tapping every 15 to 20 days, abstinent now, recently for the last 2 to 3 months. So, what are the options that we have for this patient? So, one option is liver transplant because now he's abstinent for more than 3 months. Refractory ascites has expected survival of around 6 months. So, you would offer transplant, but the patient was not interested at this stage. The second option would be to add a drug like midodrine with or without octreotide and increase the dose of diuretics once the mean arterial pressure increases. And the third option would be TIPS because he is still a low melder. Meld is 11 and any value of less than 18, we are okay with doing a TIPS for these patients with refractory ascites. So in an ideal setup, we would all go for transplant for this patient. But we know that that is still a rarity rather than the rule. So tips or adding midodrine octreotide, personal preference.
Before that, Akash, can we ask you a question?
So
In real life, of course, many patients refuse transplant. In real life, we can't offer livers to patients who need transplant as well because liver is such a rare commodity. So while we are buying time in those who agree to transplant, is there a role for IV albumin in these patients?
yes, sir. So I think after this landmark study published 2 years ago, which showed a survival benefit, reduction of morbidity, hospitalization, and in sepsis with weekly albumin therapy, I think we are increasingly moving towards once a week albumin therapy for a lot of our patients. But of course, the cost is really restrictive. One albumin injection in a private setup, the albumin itself is around 5,000 plus another 2 to 3,000, 4,000 for administering it. Around 40 to 50,000 per month is the cost. So in around 6 months, you are looking at a very huge cost. And if you add the number of hospitalizations in around 9 months to a year, it is almost equal to the cost of a transplant. So it's a very important addition. I agree with you completely. In those patients who are waiting for transplant, I think it is something very useful, but I would not offer it to somebody who doesn't have long-term prospects.
Yes, of course. It doesn't prolong life. It only, decreases or rather increases the interval from tap to tap and protects the kidney to an extent while we are buying time to transplant.
So this patient was started on midodrine 2.5 milligrams thrice a day, which was escalated to 10 milligrams thrice a day. Uh, to achieve a blood pressure of 116 by 66. The target mean arterial pressure is around 82 as per the literature. That is when you have the best results in terms of amelioration of ascites. So the problem is again the cost of midodrine. It is not something which comes very cheap, and 10 milligrams thrice a day would be like uh, 12 tablets a day, which is almost 2,500 rupees per day of midodrine. So it is not something which is cheap or easy to give. At that stage, metalazone was added with weekly albumin, like Dr. Abraham mentioned, and the ascites started decreasing, but the patient developed urinary retention, which is a known side effect of midodrine, especially with higher doses. So midodrine dose was reduced to 7.5 milligrams thrice a day. The ascites reduced, the patient felt better. The bilirubin was 1.8, INR was 1.6, albumin was 2.8 at this stage. So despite weekly albumin, it was still on the lower side. So the patient was convinced for listing for DDLT. So he had mild to moderate ascites. His tapping frequency had reduced to once in 2 months, and at this stage he got listed. So midodrine works by becoming active in the form of a metabolite called as desglyamidodrine. It's an alpha-1 agonist which acts on arteriolar and venous smooth muscles, causing vasoconstriction, thereby increasing the systemic and splenic blood pressure. Therefore, it improves the effective circular volume, and because it increases the renal perfusion pressure, therefore it improves the GFR. Uh, it, it is available in 2.5 milligram and 5 milligram forms in India and 10 milligram form elsewhere. The usual starting dose is 2.5 milligram thrice a day, but the minimum effective dose for most patients would be at least 5 milligram thrice a day. Anything less than that is usually ineffective. The maximum safe dose is 30 milligrams in a day, and the dosing interval is 4 to 8 hourly. Usually give it only during daytime, because if you give it just before the patient goes to sleep, then the person can have supine hypertension, and that is associated with increased intracranial events. The side effects one has to be aware of: supine as well as sitting hypertension, paresthesias and pruritus, mainly on the scalp, is something which we have to remember. It can cause goosebumps and chills. It can cause urinary urge and frequency, as well as retention of urine. And rarely you can have allergic symptoms with rash and flushing, dry mouth. Also, we have to be aware of the drug-drug interactions of midodrine. If you give it along with digoxin, it can cause life-threatening arrhythmias. Should avoid giving it with other drugs which can increase blood pressure, like phenylephrine, ephedrine. Do not co-administer it with thyroid hormones. There should be a gap of at least 2 hours. Ergot derivatives and salt-retaining steroids like fludrocortisone. So if the patient has relative adrenal insufficiency and he is on fludrocortisone for that, do not combine it with midodrine. Avoid combining with MAO inhibitors. Alpha blockers given for prostatic enlargement will antagonize the effects, and they will lose the benefit of giving midodrine. Interaction with metformin and ranitidine and antiarrhythmic drugs in the form of absorption is there, and therefore it is best avoided with these drugs. Unfortunately, our patients succumbed after 9 months while still awaiting for transplant. Like Professor Abraham said, on cadaver waiting list, the mortality is still almost 40 to 50%, and only half the patients get the liver. So we have to remember that if the patient has developed ascites, the median survival is around 20 months. In patients with refractory ascites, the median survival is 6 months. And by adding or giving these drugs, you do not hugely increase the survival. Maybe you'll get a few couple of months extra by using midodrine or other vasoconstrictors. It is more for quality of life than prolonging the life. Once the patient has developed spontaneous hepatic encephalopathy, the survival is around 6 to 9 months. Variceal bleed in a child acirrhotic has a good survival 5 years. In a child B, 3 years. In child C, it is only 3 months. And type 1 hepatorenal syndrome has an untreated type 1 hepatorenal syndrome has a 2-week survival, and type 2 HRS has a 6-month survival. So before you label somebody with refractory ascites, first check whether the patient is compliant with salt. Ensure that the patient is on appropriate dose of diuretics. We have corrected hypovolemia. Ensure that there is no portal vein thrombosis or hepatic vein thrombosis or any other vascular issue which is causing ascites. Please rule out use of drugs like methotrexate or salt-retaining drugs like fludrocortisone. Ensure that patient is not having severe cardiac dysfunction or grade 2 to 3 diastolic dysfunction by doing a 2D echo. Ensure that the patient is off beta blockers at this stage of developing refractory ascites, because they can themselves contribute, and rule out infections like tuberculosis. So learning points from this case: stepwise approach to ascites management. Vasopressors have an important role in those who are really refractory ascites. MAP-guided dosing for diuretics and vasopressors is required. Remember that these are only bridge to transplant. They improve the quality of life and reduce the frequency of tapping, do not add much life by themselves. TIPS is useful in low melders with no hepatic encephalopathy, and therefore should be used wherever possible. Like in our patient, it would have been equally good to use TIPS in that patient. So, any final comments and any other audience questions?
So you covered it comprehensively. There's no question about that. I learned a few points too. There are no questions on this one case, but there are questions, one or two of them, on the previous cases. Can we take them before we wind up?
Sure, sir, sure.
Okay, so one of them was from Dr. Vidya Sindhu, who asked whether, Mumbai again, who asked whether in CKD patients, is there a choice of PPI? Are all of them equally unsafe in those who have chronic kidney disease? And is there a role of PPI in acute pancreatitis or in mild reflux, and any role for sucralfate in GERD? So any choice of PPI in those who have renal dysfunction? The answer should be no.
No, there is no.
All right. Is there a role for PPI in acute pancreatitis?
No. Again, unless as a stress ulcer prophylaxis.
That's it, yes. And the third question is, in mild reflux, do we need PPI or can we get away with an H2RA?
This is an important question. I think this is something which we need to discuss. Patients who have infrequent reflux symptoms, like once in 10 days or once in a month, there are two options. We can give on-demand therapy, and the on-demand therapy could be either local antacids, topically acting antacids, or you can give on-demand PPI to these patients, or even blockers. I think all these work well for these patients. My personal choice is actually H2 blockers for these patients because it really has a very rapid onset of action along with the topical antacids.
Any role for sucralfate in GERD?
So, by and large, I don't use sucralfate for patients with GERD. It is more of a ulcer healing agent. So, like one of patients where patient has ulcer which is not healing or has severe erosive esophagitis which is not responding to PPI, like the patient which Dr. Rakesh Patel discussed. I think in one of those patients only I would use sucralfate. Otherwise, sucralfate actually will work when the pH is acidic. That is what it needs for its action. And
so co-prescription of sucralfate with PPI is illogical.
Illogical, yeah. Absolutely. Although there's some data that it may work also, but it's illogical.
So the rationale is, I'll tell you the rationale is of combining the two is, in case the PPI are not able to sufficiently suppress the acid and the pH goes below 4, the sucralfate will become active and will provide some protection. Possibly. So that will be the only logic to combine them.
Yeah. So maybe the final hurrah comes from Dr. Rakesh Patel. He's asked a question again in the patient that he described where there was erosive esophagitis despite double dose PPI. Will it help to add an antidepressant? I think if Rakesh Patel is involved in the care, an antidepressant won't be necessary. He'll take care of that. But otherwise, in your practice, would you add an antidepressant? Remember that this patient has erosive esophagitis.
In fact, I would be very worried in adding antidepressant to these patients, especially SSRIs increase the risk of GI bleeding. So, especially in somebody who has erosive esophagitis, I would be very reluctant to add antidepressants.
And this patient has erosion.
There is some point in doing biopsies of that esophagus because if the pH says that there is no significant acid reflux, he's on double dose PPI. Because rarely other esophagus can be involved in something like Crohn's or unusual conditions is more likely than functional.
Yeah, if there is erosion, it cannot be functional. Yeah, that's right. Yeah. Okay, Akash. Anirudh has some final words to say.
I think we had a very good discussion, and Akash, as usual, keeps on teaching us many things. This has been going on for, I think, 2007 onward. Akash, when did you join GI? 2007.
2005.
2005. So 15 years of uninterrupted learning for us. And we enjoyed this session, and I hope the audience has also enjoyed it as much.
Maybe we'll have a final word from the sponsors. Do they have anything to say?
So I will request Dinesh to come and
Yeah. Sir, once again, on behalf of Sun Pharma, thank you very much, Akash sir, for non-stop long academic session, more than 2 hours presentation. So thank you very much, sir. Each presentation every time is benchmarking presentation. And thank you very much, Professor Abraham and Dr. Phadke, sir, making it more informative and interactive. And I really thank to all audience. At now, currently we have more than 270 doctors attending and sparing your valuable evening with us, making this webinar, I believe, successful. And at the end, I would like to thank my colleagues, my technical team as a back-end support, making all arrangements properly. Thank you so much, sir. Thank you very much, sir.
Thank you. We enjoyed it. Thank you.
Thank you. Thank you, sir. Thank you. Have a weekend, sir. Nice weekend.
Good night, sir.
Good night.
Good night, sir.
Sir and Abraham, sir. Thank you so much.
Thank you. Good night.
Good night, sir. Good night.